Welcome, everybody from around the globe. We're so glad you could be here for Assessing for Depression and Optimizing Care using AI-based neuroimaging. This is going to be co-sponsored by our partner Rostrial as well as iMedisync. A little bit about our team. We have left to right, Cody, Chris, Carlos, and myself. That helps work with the development and sales for iMedisync North America. We also have a shout out to Dr. Kong, who's our CEO, Dr. Kim, who is on this call with us, and Dave Burkus, the president of North America, iMedisync. And a huge shout out to Rostrial, our partner. They're a master distributor with continental projection in Latin America, experts in developing and implementing strategies for highly complex technologies. It's been such a privilege working with them. They helped us finalize our slides and always inspired by the work that they do. A little bit about us is we are an AI-driven mental health platform. We utilize neuroscience measurements for EEG technology, integrated with neuroimaging HRV analysis of biomarkers, and we offer preventative monitoring and evidence-based care. And you can see we have an iSync wave just behind my shoulder here and one pictured. So the iSync wave is the device that we use for our HRV monitoring and neuroimaging, as well as photobiomodulation. The iSync brain is pictured on this slide as reports that are generated using our age and sex matched database, AI denoising, and quantitative reports such as pediatric reports, mild cognitive impairment reports, and your EEG summaries. So a little bit about us is we can be used in multiple avenues for mental health, pediatrics, PBM therapy. As in the case of this lecture, we will talk about depression, PBM, and TMS and the uses of EEG for those fields. So again, thank you for joining. We have some links here that you can follow us on our social media, schedule a demo, follow us on LinkedIn. We're very much a chatty bunch and love to hear about you, your endeavors, your projects, and also share what we have to offer to see how we could be a good fit in helping you with your practice. So next month, we have a few spots remaining for our EEG-guided neurostimulation grand rounds, where you can learn to read reports, look at the raw EEG, and develop protocols for TMS or for red light therapy. And I think we have just about 5 spots left, and you can sign up on our website. Cody, if you could put that link in the chat, that'd be great. We also have a few webinars coming up covering dementia and PBM, traumatic brain injury by neurologist Dr. Rathbone, who is also from Canada, and ADHD and medication just in time for back to school. And then in September, we have Linda Thompson, who is like the queen of EEG, I'd like to say, covering ADHD, ASD, and PBM, photobiomodulation. And now to the best part, our presenters. They're quite the dynamic duo. We have Jay Gunkelman, who is a QEGD emeritus. And I don't know if you know this, but we have a celebrity among us. Jay is filmed in a documentary, Signal in the Noise, that tells a little bit about his history and how he worked for a lab where they would analyze 100 to 200 EEG scans a day. And that gained him the amazing experience and knowledge just by repetition and diving into real cases and real people looking at their brains. We also have Dr. Karoush Edalati, who is a psychiatrist in Vancouver, Canada. He has his practice that meets all your psychiatry needs as well as TMS. And he just started his peak performance program. His journey in holistic brain health began as an immunology student at McGill University. And it kind of took off from there with his interest about the brain and the mind body connection and how it helps with our health. So, without further ado, I'm going to switch screens here so they can pull up their slides and we can begin our presentation. While you're pulling that up, I'll still brag about you a little bit, Dr. Karoush. Oh, there we go. I was gonna say
You can keep bragging. That's okay.
Okay, I'll keep going.
I'm just
I was just
messing with
gonna
you.
say you've been nicknamed the Zen Dude. I think that's an important piece to add.
Thank you, Rebecca, for the kind introduction. Hello, everybody. My name is Dr. Karoush Edalati. I'm a psychiatrist in Vancouver, British Columbia, Canada, and I'm very excited to give this talk with my good friend Jay Gunkelman. We would love to hear all of your questions at the end. So we have a very exciting webinar today that we want to present. The topic of it, of course, is going to be on depression. And we are going to also bring up many of the tools that are out there right now in terms of both diagnosing and treatment. I want to also thank our sponsors, and in particular, iMedisync for revolutionizing the AI in QEG, and very excited to go through this talk today with you. So let me just bring this up, and I don't know if everybody can see my deck.
There we go.
Okay. All right. So today we're going to talk about, first of all, depression. Everybody hopefully knows what depression is or has seen someone close by who suffers from it, and has had the privilege of maybe helping these individuals to deal with this very terrible condition. So first of all, we're going to talk about how we assess for depression, and then we are going to go into basically neuroimaging-based therapies using QEG. We're going to look at how this can be used to guide TMS, photobiomodulation, as well as Jay's favorite, which is predictive medication. So predicting basically what medications could be helpful. So I don't have to tell the audience here the global impact of depression, and this is really an underestimate. This is from 2019. My assumption is that after the pandemic, this has probably gone up significantly, given all the difficulties that we have had through this pandemic. And it is really the number one cause of disability worldwide. It really affects a lot of people, takes away a lot of productivity days from work. We know that the global economy takes a big hit uh, because of depression, and usually it comes packaged with anxiety disorders, so they're usually comorbid. In terms of diagnostic challenges, we have many conditions that could be part of the differential, so Alzheimer's, dementia, and cognitive impairment can show up and present itself as depression. They could also be comorbid. We know that 1 in 5 cases of Alzheimer's dementia is misdiagnosed as depression. iMedisync has come up with this incredible biomarker based on their AI work that can actually pick up Alzheimer's dementia with 91% accuracy. I invite you to read this paper on Frontiers of Computational Neuroscience. Very fascinating work they've done. But in general, depression is difficult as a condition to diagnose. And I think this is where these new tools can really enhance not only diagnosis, but also the treatments that we provide. The journey without these tools is oftentimes a trial and error, and you have been through some of this frustration. You've seen what happens when we have someone who goes through an SSRI, like Prozac, then tries an SNRI because the SSRI stopped working, such as Effexor. Then they try it tricyclic or tetracyclic, and then finally, last ditch effort is going through something like ECT. And if they are lucky, they also have transcranial magnetic stimulation to add to the mix. So it's a very difficult journey for a lot of people. And the difficulty of it, of course, is that there's a lot of uncertainty around number one, diagnosis, number two, treatment. So the talk today hopefully will shed some light on some of the tools that are out there that, in addition to our clinical interviewing and just a general assessment tools such as scales, can help with that. DSM-5, and of course we have the ICD-11 in international tools for diagnosis. DSM-5 basically tells us that major depressive disorder, and I'm looking only at major depressive disorder, but keep in mind that in DSM-5 there are other conditions that are part of the depressive disorder category. So depressed mood, obviously, diminished interest or anhedonia. People have either difficulty with weight loss or weight gain, hypersomnia, or not being able to sleep at all, psychomotor agitation or slowing. And this is when things get tricky with dementia, by the way. The psychomotor slowing in some individuals in dementia can be misperceived as depression. Loss of energy, lack of motivation, basically feelings of worthlessness and guilt. And finally, difficulty with concentration and inability to make decisions. Now, what I want to really invite you to pay attention to here is these symptoms that you see on the screen for DSM-5. They're very descriptive, right? So DSM-5, ICD-11, they're descriptive tools. But what we have through QEG, which is really the exciting part, is that we can actually look at brain waves and measure these objectively. Now, a QEG is not a diagnosis tool. It's suggestive of a diagnosis. I want to be really emphasizing that. And absolutely, there's a need for clinical interviewing and clinical diagnosis as well. But it is a really powerful tool that shapes our ideas of depression and how we diagnose and treat it. The other thing is some of these symptoms that you see, they're really related to parts of the brain, so networks in the brain. And this is another thing that I would like you to think about. What are these symptoms related to in terms of structures in the brain? And so functional imaging, we know that a lot of these structures now showing up and telling us what basically the clinical correlates are. And so understanding networks in the brain, understanding neuroanatomical functions and locations is very, very critical. And QEG will help us with that significantly. These are the things that we usually use in depression diagnosis. So Hamilton Depression Rating Scale, Beck's Depression Rating Scale. In children, of course, we use the CDI, or Child Depression Inventory, and of course, we go through our clinical interviews. We do our mental status examination as psychiatrists, psychologists, counselors, to come up with a clinical diagnosis. And then you have, of course, the differentials that is there. You have, as I mentioned, Alzheimer's dementia, but bipolar depression is another tricky one, because we know that most people who have a manic or a hypomanic episode, they spend a lot of their time also in depression. Anxiety disorders can be misleading, because we can have agitated depression in elderly and adolescents, typically presenting themselves as anxiety disorders. And so the tools that we are showing today can be very helpful with that. And comorbidities, which is something that you see oftentimes, again, anxiety disorders, ADHD, substance use disorders, etc. All right. So, Jay, am I gonna hand over to you here, or am I just gonna keep going? Jay, are you there?
I'm here.
Okay. Okay.
We,
Do you want me to keep going
if
with the
you
waves and then?
keep going with the slide, and we can discuss
Okay.
the differences between the various wave bands. The EEG is broken down in frequency bands from very slow to faster frequencies, and the chart here starts out with delta, which is very slow, between DC, 0 cycles a second, up to about 4 cycles a second. And that's seen during very early life and also during deep sleep, as in some pathologies as well. It's an important band to keep an eye on for white matter damage, especially, and you'll see that in autism, for instance. The theta band, theta is a broad band, 4 to 8. It sometimes includes slowed alpha. And the International Federation of Clinical Neurophysiology, um, the International Federation for Clinical Neurophysiology suggests that when you see something in the theta band, you have to determine whether it's limbically generated theta or whether it's thalamically generated slowed alpha. And that sometimes is a bit of a difficulty for determination. The slowed alpha is involved in thalamocortical dysrhythmia, which we'll talk about later, especially for the TMS application. The alpha band is what most people produce with eyes closed in a resting state at the back of their head. The visual cortex will idle between 8 and 12 cycles a second in normal adults. Young kids are very slow, 6, 7, 8 years old, they're up into the alpha band. And then people my age start to slow down as they get older. And the determination at that point whether the aging is normal, healthy aging, mild cognitive impairment, or dementia ends up being very difficult to determine. But the AI-based brain scanning here with iMedisync has given a big leg up on that determination. Beta is broken into lower frequencies of beta, and here the 12 to 15 hertz is identified. That's sometimes referred to as sensory motor rhythm, SMR. It's a frequency band that's a stabilizing rhythm within the brain, identified by Barry Sturman. And it's the important aspect of stabilizing during sleep, but also during the awake state. And we'll look at the photobiomodulation in that frequency range as having a gently activating those stable stimulation. The beta frequencies that are faster become more excitable, and the stimulation at higher frequencies can excite, but sometimes overexcite. So they have to have a stabilizing counterbalance. And then gamma frequencies are an interesting, very high frequency that's been of interest in meditation, but also in medicine. Gamma is healthy if it occurs in brief bursts, but it occasionally occurs in pathology, the seizure focus in epilepsy, the Parkinsonism, frozen postures and rigidity, the ringing in the ears of tinnitus in some cases. Not all cases of tinnitus are a dysrhythmia, but thalamocortical dysrhythmia, you see the gamma. So gamma may be pathological, but it also can be seen in advanced meditation. The Zen meditation yoga study by Richard Davidson's lab of the Dalai Lama's monks showed a huge amount of gamma in their meditative state. So we can go to the next slide, which will show some of the waveforms. So gamma, very high frequency. And again, ideally, it comes in brief bursts. If you end up looking at it using event-related synchronization, desynchronization, you'll see it timed in gamma chirps in the negative half wave of theta and the negative half wave of alpha, frontally with memory, and also frontally with movement. You'll see the gamma nested in theta. You see it nested in alpha perceptually more posteriorly. The beta frequencies are active cortical function. They are localized cortical rhythm, and they're seen in local neural pools. The alpha waves are generated in the thalamus, but it's a thalamocortical thalamic rhythm requiring feedback from the cortex back to the thalamus. And here the theta rhythms are generated even slower. Again, theta that's not slowed alpha is generated by the limbic system. It's described essentially as the nucleus accumbens providing acetylcholine via the diagonal band of Broca to the temporal lobe limbic structures. That provides rhythms in the temporal lobe structures of the hippocampus and amygdala, which are the general rhythm generators in the theta band. You'll see the nucleus accumbens at the anterior cingulate, the temporal lobe limbic structures you see temporally in the perihippocampal cortex. And then obviously delta is one of the slower rhythms that we look at. We assume it to be present during slow wave sleep as a healthy pattern, but it's also present again in white matter. Whenever the cortex is not receiving an input from white matter, you see delta in cortical sheet dipole. So large areas of the cortex will oscillate in delta when they don't get an input. So very early in life, when your cortex isn't already fully wired up, you get delta. You get delta during sleep, but you also get delta with pathology. Anything that damages your white matter will end up giving you delta. This includes the autism population. Not all autism cases, but many end up having a developmental stage where they lay down the myelin, and that's disturbed. They either over or under myelinate. Either over or under myelinating will give you delta. So that's, I think, enough on the waveforms. We can proceed on. I think this was your discussion, but I will do it if you're
You're muted, Karoush.
So
There we go.
reduced power in the alpha band, reduced power in general is one of the things that you can see in depressive individuals, but you can also see increased frontal theta activity, slowed alpha up front. There was a study in the early 1990s that looked at depressed individuals and ADD, ADHD individuals. And regardless of the diagnosis, if you had theta up front, you responded to stimulants. If you had alpha up front, you responded to antidepressants. Even in the ADD population, if you had alpha up front, you needed the antidepressants. So you can end up with a balance issue frontally. Right frontal beta gives the dominance to the right front, just like alpha gives a subdominance to the left front, because alpha is an idling rhythm and beta is an active rhythm. So the frontal balance ends up giving you an approach avoidance. If you have alpha dominant on the left, you're more depressed, less likely for an approach, you're more avoidant. Um, uh, Hypercoherence. The frontal lobe networks with various other locations, and when things network up, they lock up in phase. The waveforms lock up in time, and they'll lock up for a purpose, and then they'll dissolve that network and hook up another network. And so there's phase lock and phase shift. And that has to go on and on and on because the frontal lobe is busy. When the frontal lobe is not working, the coherence or connectivity of the front gets into a phase lock, and you end up seeing very high coherence in individuals whose frontal lobes are not actually working. They've assumed one network and they get stuck in that network. You can have the default mode network, and the salience network turns that network off and turns on the executive network. Well, that network, that's a triple network dynamics, and you can be stuck in the default mode. The frontal lobe is full of alpha and it's hyper coherent, and that's not an uncommon finding in depression. I think we've mentioned some of the asymmetries frontally. Um, it, Not everybody's depression is just frontal. If you have early life trauma and you have adverse childhood experiences, the ACEs test that's being done nowadays, um, you can end up having trauma that creates anxiety that colors your depression. And the ability to perceive facial expressions and body language is in an area equivalent to Wernicke's area on the left, which is language, but it's on the right for affect. And that area can end up being off in depressive individuals that have turned off their sensitivities to emotional input due to trauma. And we quite often see the constellation of frontal lobe disturbance along with right temporal lobe disturbance in depression, especially with anxiety or PTSD, and not an uncommon pairing. We can go ahead on to the next slide.
Just a comment on trauma, and this is again going back to DSM-5. So one of the criteria in PTSD is in fact negative cognitions, and so this basically affect perception issue that Jay just described. You can see it in both depression and also post-traumatic stress disorder. So that's a commonly shared symptom.
So this is your case. You want to go ahead and describe your case one?
So our first case is a 27-year-old female, and basically, as most DSM conditions require loss of function, so she lost her job because of missing many days, and also had very poor performance when she was present. And remember, we talked about the impact on people's productivity. So she has a history of MDD, GAD, and ADHD for about 8 years, and went through many different types of talk therapy, so cognitive behavior therapy, interpersonal psychotherapy, and also general counseling. She used different types of medications. So from different classes, actually, she used SSRI, so fluoxetine and citrulline. She used an SNRI, that would be venlafaxine or Effexor, and finally, she also used monotherapy with quetiapine or Seroquel. And these are just the medications for depression. For her generalized anxiety disorder, ADHD, she used again fluoxetine and citrulline. Those are common between depression and anxiety. and also used a long-acting methylphenidate. I can't remember if it was Concerta or Bifenton. She basically came to us really desperate because she was really not getting anywhere in life. We started a brain map, so a QEG brain map, and we used that along with our DSM-5 in the clinical interview, along with all the scales that we use to make sure that the diagnosis that was done previously is confirmed by our work. We treatment-wise recommended transcranial magnetic stimulation, photobiomodulation, and neurofeedback. Her initial Beck's depression scale, she started at BDI of 45. And after about 30 sessions of TMS and PBM, this scale went down to 12. All right, so we're gonna have now hit to the case with Jay.
So, I'm going to have to be able to share my screen. So we'll have to stop your presentation so I can start
There we
mine.
go.
So this is her most current EEG. This is not her first EEG. This is her second EEG. And the beginning is just the amp warm-up. And this is a little bit of EMG in the temporal area. First, an orientation as to what we're looking at. Frontal electrodes have F, like frontal pole 1 is the left frontal, right frontal. This is the left lateral frontal across through the frontal midline to the right lateral frontal, left temporal to right temporal, posterior temporal to posterior temporal, and then O1 and O2 occipital electrodes. So this is a referential transverse, and the reference is the global average. Nunez recommends global average or current source density montages for looking at EEG. Linked ears does not work very well. Now, this data has been cleaned up using the independent component analysis approach to take out obvious artifacts. This is done for you automatically when iSync gets your data. Their AI scrubs out the artifact and leaves you with the cleaned up EEG. You can see the rhythms go by. This is 1 second between the dark lines, 200 milliseconds between the lighter lines. So when something is a waveform and you see two of them in about 200 milliseconds, that's going to end up being 100 milliseconds a piece. So it's about a 10 hertz wave. So you can count them for a full second or estimate from a short piece. And the thing is, you can see the alpha up front. Now, this is eyes closed. We expect alpha at O1, O2 in the visual cortex. When you close the eyes, the visual cortex should go into the resting but ready state. It's not off. It's still ready. It's ready to perceive. Just open your eyes and it will perceive. So we expect alpha in the back of the head, and some of the sensory areas in the back we expect alpha. However, when we see up front lots of alpha, the alpha up front is not expected. We expect a gradient of less and less alpha as we go forward. If you see FP1 and FP2 superimposed, they virtually disappear. All of these frontal sites, the waveforms are virtually superimposable. If they are identical, they'd be a coherence of 1.0. They're not perfectly identical, little bits of difference between them, but the coherence is elevated. And unfortunately, for this person, their hypercoherence up front and their right temporal alpha intensity end up combining for affective regulation and affect perception as a combined problem. And both of these locations end up needing to be improved in order for the person to become more fully functional. So as we go through the EEG, you'll see things change once in a while. The ongoing steady EEG rhythm of alpha, this wave is not the same frequency. This is slower. This is a momentary dip in the level of vigilance with a burst of alpha right afterwards. This is light drowsing. And light drowsing is going to give us just a little bit of theta frequencies. That's not really theta, it's slowed alpha associated with drowsiness. So as we go through the EEG, the hypercoherence, the similarity of the alpha channel to channel up front is notable. The right temporal is extreme. It's bigger than the O1O2. And as we go through this, you can see the frontal alpha is just so similar. It almost looks like it was done with the same pen, just across multiple times. But again, you see subtle differences between them, but the frontal alpha is extremely stable and high in coherence. We have moments of alpha dropout. Alpha dropout is a drowsiness moment with slightly slower alpha, and then it comes back up to a persistent alpha again. So this is a normal person with a light drowsiness on and off, but the alpha is extremely stable. And with the alpha this coherent and this stable up front, and this intense in the right temporal, those areas have to be improved. Now, this will end up having a spectra that we can get of it. And the power spectra is the fast Fourier analysis. I'm going to give you traditional band ranges, delta, theta, alpha, and beta, beta 1, beta 2. So we've got a little bit of a fast edge on the alpha here. The drowsiness is what gives us the slower peak that you see. But in general, the alpha that's up front isn't just fading as you go away. It's actually gotten bigger all the way up front rostrally, suggesting that the anterior cingulate's rostral tip is the likely source of these frontal alpha peaks. They're not just the background alpha fading as you go further away. There has to be a frontal source. So this is the more current EEG, and I believe this is the most current. I showed you the first one first. That was the pre. This is the post. If you look at the alpha frequencies, they still have a relatively fast frequency. As we go through this further, you see some of the alpha dropout, little bits where the alpha doesn't stay rhythmic and some slower rhythms are occurring. So we're getting a little bit of light drowsiness even in the more current data set. But the frontal alpha and coherence are distinctly present. The right temporal is notable, but I think it was much more noticeable in the pre. This is the full spectra, and filled by band range. We now have fast alpha, the slow content. The big question is, how do the two differ? And we can compare spectra. This is the most current, the second one we did. The initial one was here. There's less of the alpha up front. There's a little bit more of the drowsiness than there was, but the alpha up front has dropped down considerably, and the temporal alpha has dropped down considerably. So a little bit of faster alpha has started to happen, and faster alpha is superior semantic and declarative memory. Slower alpha that has decreased. This is the alpha below 10. The slower alpha from 8 to 10 is poor semantic and declarative memory performance when the peak is there, superior if it's faster. So we've gained faster alpha, we've lost slower alpha. In general, less slow, more fast is a brain brightening effect. So both temporal lobes alpha went down, the frontal lobe alpha went down. You have a little bit of a brighter, and then the client did have a bit of drowsing. And again, filled by traditional bands, you can see alpha has gone down. So this was that comparison. This is the pre absolute power z-scores. A z-score normal is at the green, excess is crimson red, and deficit gets into the darker blues, almost black. And you can see this EEG is in the alpha band, which starts at 8, 9, 10, 11, 12. It's more in the fast edge of alpha, and we're full of beta in the EEG and gamma in the EEG. This EEG is really not working well. It's grossly over aroused. And when you look at the alpha frequency from 8 to 12, and you see it's all loaded in fast alpha, you can predict that the SSRI and SNRI classes are not going to be fully therapeutic. They give an increase in arousal, and this brain doesn't need an increase in arousal. They'll increase some beta. This EEG doesn't need an increase in beta. So the things that SSRI does to the EEG are not things that this EEG needs. This EEG basically could use a tetracyclic, which is given at night and it makes you sleepy. It reduces the beta in the EEG, slows the alpha slightly. It has an anti-anxiety effect during the day. So this EEG predicts some specific changes in pharmacological approach, and a tetracyclic antidepressant may be effective here, but the classic antidepressants are less effective and usually cause an overarousal, especially when there's beta and fast alpha. Now, this is the current, the first one. This is the current one, the same z-scores. And it's not like we changed this is the same numbers at the two ends of the z-score. So the slow content is wound down. We have some theta, again, because of drowsing. And our alpha, if I go back, you see, way is 12 hertz and up, but it has significant elevations even in the slower alpha. The current one, all of these have normalized. These are approaching normal. There's a little bit of an excess still right temporally. The alpha still remains at 12, 13, 14. There's still some beta and some gamma, but this EEG has normalized dramatically from its initial presentation. And the clinical case reflects that as well. Anyway, that's the quick rundown from my end. I'll stop this. You can resume the PowerPoint. I'll jump back in after your second case pops up.
I was going to re-share my screen here. Get us back to
There we go.
Okay, so I just covered this here. Okay, so we got the second case here. 18-year-old right-handed male, and again, severe issues at school due to depression and also some OCD symptoms. The OCD symptoms are actually mild, but the depression was quite severe. He has a 5-year history of both conditions, and again, they use exposure response prevention, which is part of CBT profile for the OCD, but also they use cognitive behavioral therapy for depression, IPT, and again, general counseling. Uh, this time, the medications that were used are fluoxetine, fluvoxamine, which is Luvox, and then of course the gold standard for OCD, which is a very highly serotonergic agent, is clomipramine. So they use that as well. We had the same basically approach, QEG brain map, clinical interview with DSM-5. We recommended pretty much the same thing. In terms of the depression scale, the CDI was 42. And so I stand corrected. Actually, this case, the OCD was quite heavy as well. So the CY box, which is the scale we use for OCD, was 38. After about 36 sessions of TMS and PBM, we had a CDI of 16 and the CY box of 12. All right, so this is case 2. I'm gonna stop here, Jay, so you can go into your screen.
Okay, and thanks for the handoff. Amp warm up again. Now, you saw the last EEG had somewhat of a faster alpha rhythm. You can count them for a second here. Starts just outside the line. 1, 2, 3, 4, 5, 6, 7, 8.5. And that's not very fast. It's in the alpha band, but it's barely in the alpha band. And some of it looks like it may not stay in the alpha band. As they mentioned, he had some difficulties in school, and we do have some temporal irregularities in the EEG, slightly slower alpha rhythms in the temporal lobe. If you look at the right temporal and left temporal, you can see Wernicke's area has got a little bit of an irregular, slower feature, and the right temporal area, which is affective perception, has a fairly significant transient, irregular, slower event. This EEG is not the over-arousal one that we saw, but this one also has arousal issues. This transient that you see here is part of the wake-sleep transitional state discharge. When you're going from awake to drowsy, where the alpha is not as organized, back to alpha, back to disorganized, transients tend to occur. And again, you can see this right posterior temporal parietal junction, which perceives emotion and facial expressions and body language, the emotional tone of speech, it's not doing so well. It's got an excess idling in the eyes closed condition with transient slow bursts in it. Now, this EEG has, again, vigilance issues, the waxing and waning of the level of vigilance. There's actually a formal model in Europe that the psychiatry groups in Europe use to predict medication, and they look at things that reflect vigilance, the amount of anteriorized alpha or anteriorized theta, which suggests the frontal lobe is not as active, and the dynamics moment to moment to moment showing the regulation of that. It ends up being what they look at. there's a nice book on theoretical interpretation of the EEG by Gerald Ulrich, a retired psychiatrist from Berlin, classically trained. You can see his classic education in his writing. The EEG here is not up to the normal speed. You saw a very drowsy moment go through. They're getting some more steady state background alpha back, but he has difficulty maintaining persistent, organized alpha all the way through. You can see again drowsiness entering in to this EEG. So this is his EEG 1, the presenting pre-treatment EEG. This is his spectra. And you can see the affect perceptual area that we've talked about, the right posterior temporal. And this is like looking straight down on the top, left frontal, left temporal, right posterior temporal. The equivalent of Wernicke's area, which would be language on the left, he's got that issue here. On the right temporal, intense alpha. This is the faster alpha frequency you see in the back of the head, as well as the slower alpha that you end up seeing in the EEG, and probably some even slower that pop up during drowsiness, similar to what we saw in the last case. But everything points to this right temporal deviation. And although we have anteriorized alpha, and the anteriorized alpha is excessive, and it's a deviant alpha. This is not alpha at 10, 11, 12. This is alpha, peaking with a normal peak and a slow peak. The slow peak variability ends up being shifts in vigilance, faster alpha and slower alpha. And obviously, you can see the alphas all the way forward, again, bigger rostrally than at the frontal plane, suggesting the anteriorized at the affective division of the anterior cingulates involved in this. The right temporal finding and the anterior changes are, this is in the initial study. I'm going to open the follow-up eyes closed. So eyes closed 2. You can see the slower content of drowsing. But alpha, when it comes together, is looking much more organized and faster. Instead of being an 8, this is an organized run of it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 and a half. So he's come up to faster alpha. Seniors who experience speeding up of alpha from the 8, 9 to the 10, 11, 12 refer to the experience as brain brightening. Your background alpha is your sampling rate. How many perceptual snapshots of the world are you taking in a second? And a higher sample rate gives you a higher resolution, crisper perception, sharper memory. All of that comes together with faster alpha. And this episode is not the only episode of faster alpha. Now, he does have slower, drowsy still going on, but this follow-up EEG, as you know, after treatment, ends up having faster alpha in the mix. Now, what we need to do is create the same kind of graphics. You can see the pre and post. This is not the same pattern, and we've got a 10 hertz alpha. There's still a deviation here, but it's not anything like it had been. And if we look at the difference between pre-treatment to post-treatment, most recent minus the prior, what we see is a decrease in the slow alpha and slowing. There's an increase in the faster alpha. There's less slow, more fast. As a pattern, less slow, more fast is a brain brightening speed up of the background alpha. The decrease and the increase are almost identical. There's a little bit more increase than decrease. So overall, there might have just been a little bit of a bump in the size of the alpha comparatively. Up front, all that slow alpha and slow wing went down. We still have alpha up front, but it's fast alpha now. So a fairly substantial change, but let's look at it with a different set of eyes. This is the pre-condition with all the slow content. Again, this is z-score. This is 1, 2, 3. This is 4, 5, 6, 7, 8. This is theta content, but it's there because of slowed alpha. You can see the right temporal here at 9 and 8 and 7 and the 6 and 5. The temporal deviation on the right side for affect, and then obviously the frontal alpha. The frontal alpha at 11 is skewed to the right, which would be more of an agitated depression or anxiety, and the balance of right to left. At one point, there was a study by Davidson that said alpha was left frontal alpha, but it was only the group that he did. And the iSpot-D study with over 3,000 people looked at the overall EEG, QEEG pattern and did not see left frontal alpha. It's more complex than that. There is a subset of women that have left frontal alpha that all respond extremely positively to SSRIs, but it doesn't characterize all of the depression, and this is one of those cases that wouldn't be just pure frontal alpha. There's a lot of slow content and a lot of frontal disturbance in fast activity as well. The follow-up, the post, a lot less of the deviation in the very fast frequencies. The slow content is moderated some, but it still has an excess in the right temporal area. And the 10, 11 right frontal deviation that was there is no longer there. There's some full normalization, but the right temporal and frontal areas still need some attention. So this person, unlike the last person, may respond well to stimulation just above 10 hertz with a TMS machine. The last person whose EEG had dominant alpha up at 12, 13, 14, 10 hertz left frontally, which is commonly done with TMS. They're trying to stimulate the beam F3 location. Beam actually stands for brain electrical activity monitor. It's an archaic term holdover from an early QEG machine. There were only a couple of them ever made. They required mini computers and air conditioning and static control. It was a nightmare to manage and keep up running, but it was one of the first major QEG machines at Harvard, for instance. And the beam was popularized because of its early QEG application, and they still use the location of the F3 electrode basically to target the left frontal gyrus that they believe stimulating will end up activating the person and getting rid of their depression. I have to say that not all depressives respond to TMS at classical beam F3 10. 10 hertz stimulation at F3 is good for somebody like this, maybe, especially if you boost it at a couple of cycles a second. If you're a little faster than their background activity, you're going to stimulate them. 1 hertz is inhibitory. 10 hertz is supposed to be excitatory, and sometimes it is, sometimes it isn't. The reason that sometimes it isn't is sometimes the alpha is faster than that 10. And that was the classic Neurostar, first QEG machine approved in the US by FDA. Brainsway stimulates theirs up at 18 hertz, which is going to be stimulating. 1 is inhibitory, 18 is definitely excitatory. And the Brainsway would be something that could excite the overexcited frontal lobe of the person who had too much beta and too much fast frontal alpha. But in fact, inhibiting them up front with getting rid of the beta with a 1 hertz may be something to end up balancing in somebody that ends up having a frontal deviation like that. I'm going to jump out of this, and we have, I believe, already, you can go ahead and proceed on. We've got more PowerPoint to go.
So I need you to unshare so I can
Okay,
I
my
can share.
apologies.
Yeah,
My
that's okay.
apologies.
Perfect. Okay, so gonna get back to our. Okay, so Jay already alluded to use of TMS based on the QEG, and so what this tool really provides, this QEG gives us an idea of whether we really need to inhibit or cause excitation, stimulate the frontal lobe. And so what we have here is a tool that is really in two different, it comes in two different kind of shapes. One comes in the shape of a coil. And so this is what we call the H1 coil or the H7 coil. This is the Brainsway or deep TMS that Jay was alluding to. And typically the level of stimulation is much more pronounced. And then you have the figure of eight coils, and these are kind of the traditional coils. And again, as Jay was mentioning to you, 18 hertz for Brainsway is excitatory, 10 hertz for the figure of eight coils is excitatory, and then of course you have the 1 hertz, which is inhibitory. So what is TMS? And TMS basically is a very powerful magnet that is placed based on uh, mapping of the brain, knowing which areas of brain are involved in depression, mood regulation, and of course, not every brain is the same, so you have to always keep that in mind. And what may be helpful as a stimulatory tool for one patient, you may not be able to use the same in the next patient. So this is where the QEG becomes really useful. It is an FDA-approved treatment. It's non-invasive, and really what it is a giant magnetic uh, coil. And this magnetic coil creates electrical current, microelectrical currents in the structures that are immediately below. And this will allow basically across the synaptic cleft, increase the transmission, and this is one of the primary ways that TMS works. Of course, along with that comes some risks that have to be excluded. And from my experience, we've worked with a lot of patients with TMS. We have yet to have one case of a person having a seizure during the TMS, but never say never. So one of the things we use is a task screen. Basically, this screen is a TMS screen, allows us to make sure we rule out anyone with susceptibility to seizures. And usually this comes also through the clinical interview process. We make sure that medications that can reduce the seizure threshold, such as the Wellbutrin or bupropion, is not really something that the patient is taking at high doses. And of course, we look at the seizure history and if they have childhood seizures. Now, this is a very critical point also. When you're using TMS, you want to make sure that you really do a thorough seizure clinical history. Sometimes people come in and they've had a pseudo seizure, which is usually an anxiety-based seizure. And there's no real QEG monitor, or I should say EEG monitoring overnight with sleep deprivation to have diagnosed this individual with a seizure disorder. So in cases like that, you still go ahead with your TMS, but you really got to make sure that this is clear. Um, of course, if you have a magnetic and you've probably been through MRIs or know someone who's been through an MRI, you don't want to have a metal in the person's head. It heats up because of the TMS, and that's a very unpleasant surprise to find. So we make sure that's also not the case. The EEG indicators that we look for, typically what you see in depression, but I mean, in general, most of the cases that you see with depression, as we described in the previous slide, such as asymmetric alpha and frontally, as well as hypercoherent alpha frontally. If you have a lot of beta in general in the frontal area, especially beta spindles, things like that, we look at and we decide whether we use a purely depression protocol or if they have a comorbid anxiety. For example, if they have a lot of beta, frontal beta, and especially beta spindling, high frequency beta, we would also consider to use sometimes things that can really reduce that hyperexcitability in terms of the protocols that we use. So we would use a combined anxiety depression protocol. So the other tool that we use, and this is the exciting part, because the headsets from iMedisync, they have also the photobiomodulation, which is very exciting. So you get the QEG and the TPBM. It's a very promising tool that's really out there, transcranial photobiomodulation. It's a type of light therapy. It uses either red or near infrared light. And what it does is basically it works on mitochondria in the brain. And these mitochondria, of course, are, as you know, organelles involved in ATP production, which is a major source of energy in the brain. And the way it works is it works on specific enzyme called cytochrome C oxidase. And this activation causes reduction of difficulties with oxidative stress. And one of the things that we also see is inflammation is reduced. We have neurogenesis. We see synapses oftentimes expanding using photobiomodulation. And this can really have major implications in brain health and mental health, and especially in depression. We used in our situations, or the previous patients that you saw, we used about 14 to 16 hertz, if my memory serves me right, and that helped the persons get out of their depressive symptoms. It is a non-invasive, so it kind of looks like a helmet, as you can see, and it allows the person to be basically doing their their task, and they could even put this on their head, and it's just running in the background. We use very specific wavelengths, so typically 600 to 1100 nanometers, and this is the wavelengths that I was talking about, red or near infrared light. And these are some of the pictures just to show you all the things that it does. So you can see that we get increased synaptogenesis, which is really critical with somebody who has depression, given that their inhibition most of the time, I'm not talking about all depression, but most in depression cases that you know of, there is quite a bit of inhibition at the level of the synapse. So increased synaptogenesis is critical. You get increased angiogenesis, which is increasing blood vessel growth. Blood flow, of course, increases, and with that, oxygenation of the brain increases. So you have a number of listed basically benefits coming from photobiomodulation. So when we look at photobiomodulation, and we can see here on the graph as well with respect to the raise in terms of the level of response across the bandwidth. So typically, we know that with ischemia, which is really another word for lack of oxygen, and usually it's inadequate blood supply that leads to ischemia. We have alpha getting basically slower in some areas of the brain, especially when you're talking about depression. Left dorsolateral prefrontal cortex is one of the areas that we focus on. And what we see is that with a 12 to 14 hertz frequency, using a PBM, we can actually increase cerebral blood flow. And of course, with that, we are going to be stimulating the front lobe in a way that different functions of the frontal lobe that involve three separate networks. And the networks are called default mode network. And if you have worked with QEG, these three networks are typically what you will come across: default mode network, salience network, and the executive network of the brain. These three networks really work together. A default mode network is, as the name suggests, a network that kind of puts us in a standby mode. And really, what we want to do is when we want to activate the frontal lobe, we want to get ourselves out of the complete dominance by default mode and get the individual to activate their executive functioning. And so this is when we come to salience and the central executive networks. One of the things that we also know that with respect to photobiomodulation, we can increase the range of our frequencies, and these can actually enhance further functions such as motor control. And typically, we can see this during some of the tasks that are performed, and we measure this with something called ERP. All right.
Can you go back? Can you go back to this slide? I'd like to describe the graphics one more step. You can see that there's three lines going across. The bottom line is linked ears, and the linked ear montage does not give you accurate measurements locally. It's looking at the difference between the ear and the local function. The lines at the top that are all correlating well with local function are Laplacian techniques that are looking at the local function, either global average or local average. And these two end up corresponding nicely with the hypoperfusion of the alpha band. At about 11, 12 hertz, it goes into a neutral positive perfusion, not above the statistical level, but not up to 2 or 3 standard deviations of hyperperfusion. So we need to gently activate. In ischemia, if you overactivate, you'll cause further damage, which is why some people with severe trauma are put into a coma temporarily while the brain heals, because you don't want to waste energy on the maintenance of consciousness when the brain needs to heal. And if you put the brain on task beyond the compromised ability of the impaired supply to provide it, the hypoxia can create anoxia, which can create cell death, and you don't want to do that with your patients. So this neutral positive perfusion range is what we use for photobiomodulation, gentle stimulation. The faster frequencies up here will activate. 15 to 18 hertz will be activating for photobiomodulation. You'll get a more active cortex. You're forcing the brain into frequencies that are hyperperfusion the brain on. So you have to be careful where you point the frequencies when you're doing the photobiomodulation. You want to be gentle with stimulation with trauma where there's ischemia, or migraine where there's ischemia, or aging where there's ischemia. Again, the gentle 12 to 14 hertz range ends up being very beneficial. It's enough on to open up the blood vessels with use, but it's not so much on that you're going to cause cell death. and by accidentally overdoing it. And again, this graphic was based on a work out of UCLA, Ian Cook and Andy Luchter's NPI lab, published, I think, in the 1990, if I'm not mistaken. But they haven't changed the relationship between perfusion and EG frequencies since then. So it's still quite a nice, valid piece of science.
Thank you, Jay. Okay, so now we're just going to talk about medication, predicting medications, and how often those of us who prescribe medications, we've had this difficulty where we are tired of trial and error, and I think the patients are also tired of trial and error. So QEG is a very powerful tool in that it can help us actually identify the responders to very specific medications. Now, in our center, we also use pharmacogenomics because it helps us confirm further even what we are seeing on the screen right now. And what we see here is that there are certain patterns associated with responses to certain antidepressants. So starting with theta and delta activity, and if we see basically, in the case that Jay was showing you, there was some frontal theta as well. And so frontal theta and delta activities typically respond to a medication such as SNRI. This would be Effexor, venlafaxine, or NDRI. So these are the class associated with Wellbutrin, which is the main medication. So it's a norepinephrine and dopamine reuptake inhibitor. The other things that we see here is excess beta spindles and frontal beta asymmetry. So response would usually entail anticonvulsants such as lamotrigine. And also we have the alpha-2 agonists such as guanfacine and clonidine. So these typically would dampen the excess beta frontally and would really help this patient. Alpha asymmetry and frequency, typically what we see is that if somebody has alpha asymmetry, in the case we saw there, they may respond to SSRIs. In our situation, they didn't actually. This patient, she didn't respond to that. And one of the things that Jay was suggesting is, of course, trazodone. So a tetracyclic. We didn't really try it out because I think the patient was getting better, but this is something to consider. If it's a fast alpha frontally, if it's a slow alpha, of course, SNRIs such as Effexor would be useful. So what we see here is that there is the ability to predict based on the QEG what medications to use: slow alpha, fast alpha, excess beta, or excess delta and theta frontally. And Jay is going to cover now this amazing table that he's been a part of as well.
So in 2005, I published a paper on EG endophenotypes. And essentially, the paper was a retrospective look back at over 500,000 EEGs that I had processed over the years. And I identified a series of common patterns that I saw. And I noticed in the listing of common patterns I saw, there were two that had known genetic correlates, which meant they were endophenotypic. The other 9 common patterns I suggested in that paper were candidate phenotypes because the genetics hadn't been identified yet. Since we published, the genetics have in fact been identified. And luckily, when you publish a retrospective paper, it's kind of terrifying because it's like driving the car looking out the rearview mirror if people follow your advice. So this is what happened in the past, and these are the things I saw. I had to publish it so that, like anything published, it can be tested. Theories can be tested. So what I basically did was match up EG patterns, which classifications are here, the description of the EEG pattern is in the middle, and how we actually treat the patient with pharmacology and or other approaches, neurofeedback being one of them at the time that I published the paper. But obviously medication is the focus at this point. If you have epileptiform content, you obviously would choose to use an anticonvulsant. However, if you go to a neurologist and you show them an EEG with epileptiform content and ask for an anticonvulsant, unless you're actually having a seizure, it's common for them to say, no, we don't treat the EEG, we treat the patient. I always answer back, who do you think made this EEG? You know, I didn't do this with a Sharpie. So this is actually the patient's data. And what we found is in non-epileptic psychiatric patients who had epileptiform content in their EEG, and we recommended an anticonvulsant, and they actually gave it, we had an 85% positive response to the use of the anticonvulsant in psychiatry. Not that they changed seizures, because there were no seizures. 85% positive impact psychiatrically when you match the EEG finding. Now, you think, well, EEG discharges aren't that common, are they? Well, 60 to 70% of the autism cases have epileptiform discharges. 25 to 30% of the ADD cases. A third of all psychiatric cases. Anxiety, only 12%, but the background population's only 3%. So that's a 400% increase above background. But if you also have panic, it goes up to 30%. So anxiety with panic, again, 30% of those end up having epileptiform content in the EEG. So it's not that uncommon to cross paths with these clinical cases that have epileptiform content, even though they don't have seizures. So when you do the EEG and you see the epileptiform content, if you refer to the neurologist, you may or may not get them to treat, because again, unless they're having seizures of some kind, they'll usually choose not to treat. So,
So Jay, I just wanted to make a comment here, in terms of my own clinic and practice. And you get this ADD kid, this ADHD kid, or this autistic kid who has an outburst in school. And oftentimes, of course, they're thinking that this kid is actually just having an outburst, bad behavior. But then when you look at their EEG, you're surprised that you find these transients. And it's amazing that a bit of anticonvulsant, it actually dampens these behavioral outbursts. So what I have seen clinically is oftentimes these kids are having these transient spikes before the behavioral outbursts happen. And anticonvulsants in many of these cases can actually help reduce that.
So not every kid that comes in has that endophenotype, but they can end up having that phenotype along with another one. Endophenotypes are genetically linked, but they're not necessarily exclusive of other endophenotypes. The low voltage fast EEG, for instance, is an endophenotypic pattern. Gene number 4 controls GABA A receptors, and you saturate yourself with receptors you can't saturate. So you're over aroused due to the overproduction of GABA A receptors. And this is a common pattern in alcoholism and drug addiction. And it has classically been seen to respond positively, basically to interventions changing the low voltage fast pattern into a pattern that has alpha in it. And photobiomodulation with alpha in it for somebody who has a low voltage fast pattern will end up helping to foster that. So diffuse slow activity is a diffuse encephalopathy. And delta and theta, they need some kind of a stimulant. Again, an SNRI was discussed just a moment ago for people that had delta and theta in their EEG. The focal abnormalities. Now, focal abnormalities are an opportunity to get a referral to somebody to find out what's the problem at. This is not a normal psychiatric patient when you get a focal abnormality like this. It might be a brain tumor, maybe an abscess, maybe subdural hematoma. There's some problem that's focal or local. It's an opportunity to refer. Uh, Mixed, fast, and slow. This is a very difficult phenotype to end up treating. They're easy if it's just fast, you can sedate them some and that helps. If they're all slow, you can excite them. But if they have fast and slow, what you treat the fast with will make the slow worse and vice versa. So here, Sandra Liu from UCLA's Seminal Research just published a nice paper recently, a couple years ago, on methylphenidate being used to target theta in the EEG, and if there's concurrent beta spindling, that guanfacine be used. But again, other channel blockers like clonidine could be used as well. Clonidine has been popularized for adults with PTSD by Bessel van der Kolk's work, but clonidine here in the work for kids was used, and that's Intuniv or 10x as brand names for the guanfacine. Frontal lobe disturbances. Your frontal lobe can end up having theta or alpha or beta, and you're going to look very much the same. The frontal lobe not working is the symptom you're going to see. So attentional and affective regulation is going to be off. And again, sometimes you see beta. If you do, it changes your TMS over to 1 hertz instead of 10 or faster. Your frontal lobe may have theta in it, in which case a stimulant, that methylphenidate, dopamine reuptake inhibitor, because frontocentral theta is a dopamine deficit marker. And that again was identified. Yuri Kropotov in his book on EEG identified it nicely, but it's also identified well in Sandra Liu's paper from UCLA Seminal Research. Frontal alpha. If you have slow alpha, you need an SNRI. If you have normal frequency alpha below 10, an SSRI will work very well. If you have concurrent beta or very fast alpha, a tetracyclic will work nicely. So the frontal lobe disturbance isn't just one pattern, it's the frontal lobe being disturbed. This was actually tested, the theta frontally predicting the use of methylphenidate. I walked in to do a lecture for Martijn Arns, and he presented 49 ADD kids, EEG QEEGs, and 49 matched controls, and I had to identify which kids in the ADD group responded to methylphenidate blind to anything but their EEG. And it was quite accurate. They've offered $5,000 to anybody who can get a better guess, basically, using any other method. And the vigilance modeling people in Europe tried, but it's very brief EEG samples from brain resource companies. So they didn't have their 10 minutes of EEG, so it's not really a fair test of their method. But so far, nobody's got the 5,000, and they didn't offer it to us in the first place, by the way. It was just a freebie when I was walking in for the lecture the next day. And 49 ADD and 49 match controls took me about 2.5 hours. Yeah, just going right down through them. But then that used to be a day's work. So yeah, not that unusual. If you're just flipping through the EEGs, not having to take the histories and run the machines, you can do it fairly quickly. Excess temporal lobe alpha. Obviously, if you've got temporal lobe alpha, it needs a stimulant, but it can't be a significant stimulant. It has to be a gentle stimulation. You can't use massive doses. Temporal lobe alpha quite often is slow, and suggest ischemia, and you have to be careful for that. Fast alpha variants that are not low voltage need GABA or a reduction in glutamate. And spindling beta, actually, we did a research domain criteria paper on beta spindles in the EEG independent of the DSM. We had about 2,000 patients de-identified, and we just asked, give me all the ones that had beta spindles and all the lists of symptoms. And the most common symptom with beta spindling at CZ is insomnia. Frontally, the beta spindles correspond more with impulsivity and hyperactivity, but they come together in kind of a triangle of frontal and vertex. So it's not uncommon to end up seeing a combination of those. Spindling excess beta was originally described in the 1930s by Gibbs and Gibbs. They discovered it in epilepsy in Lennox's lab at Harvard in the early 1930s, right after EEG was described by Berger. And they identified it in epilepsy, and it's still seen in epilepsy. The tonic form of tonic-clonic seizure is a beta spindle. The polyspike discharges are beta spindles, and beta spindles are commonly seen in the focus in epilepsy. So beta spindles were originally described in epilepsy. However, they're also seen in bipolar disorder and other things. So it's not diagnostic of anything. It indicates hyperexcitable cortex. And depending upon where that is, you get a different outcome. Spindling excess beta in the back of the head would give you sensory sensitivities, not attentional or affective changes. So, and the last one, persistent eyes open alpha, they usually also have mu concomitant with this. They're basically disengaged. They're not their mirror neurons aren't being turned on by anything outside of them. They're just disengaged, and they need to end up getting activated. They're stuck in the default mode. If you want to get somebody who's stuck in the default mode unstuck, you don't fiddle around with the back of the head where all that alpha is. You go right to the salience network primary hub at FZ, and you do some stimulation in the 15 to 18 hertz range. That's going to stimulate the salience network to turn on. That turns off the default mode, which is all that excess stable alpha that's not responding, and puts them in executive mode. So if they're sitting there stuck in the default mode, don't fiddle around with all that excess alpha in the back, trying to redo it or anything. Stimulate the counter to it, which is the salience network. The triple networks end up constantly revolving. You're relaxing in your cave as a caveman, and you see something in the corner of your eye that's got a little curve to it. That's salient. It could be a snake. So the central executive looks a little bit more deeply. If it is a snake, you have to respond. If it isn't a snake, well, I can go back to the default mode. So, that resting state, something catches your attention, something salient, and then central executive. I have to say that the salience network is not always called the salience network. It's also in pain management referred to as the distress network. There's nothing more salient than your distress. So when we've seen pain patients looking for thalamocortical dysrhythmias, we've actually suggested that. So I think we've got the persistent eyes open alpha. Basically, you need to activate, and again, the salience network is what you need to activate. This paper was from 2005, and luckily it's worked out fairly well when it's been tested. It stood up to the challenges that have been thrown at it. So the original observations seem to be valid, and the genetics that have been matched up with it entirely have not all been published because Johnson & Johnson, their contracts don't allow me to talk about what they found, and they consider that market edge. If today Karoush and I whipped up a batch of meds in the tub, like old bathtub gin. And it was good, perfectly effective for 25, 30% of the autism population that would be normal, just like that with one dose. How could we show that it was effective? 70% of them wouldn't respond to it. So if you have an endophenotype that classifies the patient as somebody who would respond to the medication, now you have a targeted population that respond to a psychiatric medication that would otherwise not be able to be shown to be effective. So Johnson & Johnson views the endophenotype genetic correlates that they've found to be essentially market edge. And until somebody else finds things, they don't talk about them. Martijn Arns found some with swab DNA and published about that, but the Johnson & Johnson data is still, unfortunately, still buried. I'm done with the slide. So.
Right. Well, first of all, Jay, it's amazing how you predicted all of this before the genes showed up on the on the horizon. I mean,
Well,
and it speaks to the power of EEG and how these patterns can be very, very useful in determining the outcome of certain treatments.
and
So
brains are great pattern detectors. You just have to expose them to enough. And they've actually inquired with AI about AI and how long they think it might take AI to replace other methods of determining what psychiatric presentation is there and everything. And AI predicted that it was going to take hundreds of thousands. And my response was probably 500,000. So that it after you've seen enough of them, uh, that the haze of the differences kind of fall away and the commonalities start to stand out. Now, within the patterns I've seen, there's probably coherence patterns that are deviant from one person to the next. There's further subgroupings that probably could be done. But for a 2005 observation, looking back, 30 years of EEG work, it turned out to be a good thing to have published. So.